Very good evening, students. I'm Dr. Khushbu Mahajan, your dermatology educator, and today I'm here to discuss with you the FMGE recall questions, which a lot of you attempted yesterday. So please remember, this is a recall session, so all the questions that I would be discussing in this PPT would be recall based, and our main motive is to help you understand that how did you fare in your exam, and I'm sure you did well, and also to get actual questions. So you can help me out over there. You can tell me if there were other options, or if there was something else in the question, or they had asked something. So these are recall questions which some of you only have told us, so there might be a little discrepancy in what you attempted and what you got the answer. So here then I would also say that a lot of people, they start calculating their marks based on what answers I give you here, but again, these are recall questions, so options may have been different, the question may have been different, and that would change your answer. So don't try to really pick up your marks based on this. Just try to understand and help me out with the actual questions that came out in the exam. Okay, so final questions which we'll receive after discussion will be uploaded in the PrepLadder app. So coming to the one of the questions that I received. I'll not say it's the first question. So, a patient presented with multiple painful blisters on an erythematous base along a dermatome on a trunk as shown in the image. Now, in this question, whatever be the question, if there was an image which was given to you of a dermatome where and there was something in the history which told you about multiple painful blisters, you do not even have to think twice. It is herpes zoster. Now, the important pointers which may have been there in the question or on the image are, so one is strictly a dermatome involvement, one side of the body being involved, and then the second important thing is painful blisters. I always tell the students that in dermatology there are very few conditions where the patient would walk in the OPD with the pain. So when you get painful blisters in the question or a dermatomal distribution, if these two things are present, there is no other DD for you. You have to think of herpes zoster. Because why? What is herpes zoster? Herpes zoster is varicella zoster virus. It's a virus which causes chickenpox. When there is chickenpox, this virus stays latent in one of the dorsal root ganglion, and then later in life it reactivates and presents in the dermatomal distribution with very severe painful blisters. Erythematous base is not important, area is not important. So what is important here is dermatome, presence of painful blisters, and an image which is showing that the lesions are typically on a particular area of the body, a particular dermatome with painful blisters. Now let's look at the other option. Probably there was something else in the question. So I'll quickly discuss the other option. So herpes simplex. So what is herpes simplex? It's caused by herpes simplex virus. There also you might get vesicles, but where? Usually where? Usually if they're asking you herpes simplex infection, either they'll give you an oral mucosa or a genital area, where we are thinking of either herpetic gingival stomatitis, herpes genitalis, or herpes labialis on the lips. That would again be painful, but there would be no correlation to a dermatome or something. HS is not related to a dermatome. Molluscum contagiosum does not present with blisters, is never painful, again is never dermatomal. It would present with umbilicated papules. So if there was something like umbilicated papules, then molluscum contagiosum would be the option. Now coming to chickenpox, as I told you, herpes zoster and chickenpox are both caused by varicella zoster virus. But is this chickenpox? No, not at all. Chickenpox would typically be polymorphic, so multiple different types of lesions. There may be papules, there may be pustules, and there may be vesicles. Now, they may be present on erythematous base. So, what can confuse you here is an erythematous base, because we know that in chickenpox we have dewdrop in rose petal appearance. So, we have a vesicle which is sitting on an erythematous base. But that's different. You do not have painful lesions, you do not have it on dermatome. And if an image is given to you, it will be given of a trunk which is showing a polymorphic lesion where there are multiple macules, papules, vesicles sitting on an erythematous base. So I hope it is clear. So whatever be the options, and if there was some discrepancy in the question, I think it was more or less a very straightforward question for you and you could have answered it. Coming to the next question, a 3-month-old child presented to the hospital with bright red birthmark as shown in the image. What will be the diagnosis? So here I have a 3-month-old infant and I see a red mark which is there on the eyes. To be very, as a layman term, a red mark which is there, a red plaque which is there. Now, a red plaque presenting in a child who's 3 months old, present typically on one side, would be either a vascular hemangioma, a vascular tumor, or a vascular malformation. So it can either be a port wine stain or a vascular malformation, or it can be a vascular tumor which is called as capillary hemangioma or infantile hemangioma. This is I'm talking about if there is a red mark which is present in a 3-month-old. Now, how do you differentiate? Though whatever options I got, there was no option of vascular malformation here. So straight away my answer goes to capillary hemangioma. But I'm just discussing that what would be the closest DD which might have confused you. So if there was a vascular malformation, important points that you need to know to differentiate them is this will be present since birth, whereas vascular tumor develops by 1 month of age, and vascular tumor has stages. It will be small to begin with, then it will grow, and then by 9 months it would resolve. Okay, so if they want you to differentiate between these two, they would have given you something like that in the question. Now, second important point here, look at the image that was given to you. So if this was an image, it was more of a proliferative image, a growth image, then again it points towards more of hemangioma. Port wine stain or vascular malformation are usually more flatter. They may be a corrugated surface, but they're usually flatter. The other options which have been given, I think the students confused it with the previous one, but molluscum contagiosum, I already said, are umbilicated papules. Chicken pox will present with vesicles, and herpes zoster we already discussed. So the other, I think the closest DD which would have been there probably is a vascular malformation. But if the image was something like this, if it had mentioned something about the lesion growing and then resolving, or you could see these growths on the surface, you should mark capillary hemangioma or infantile hemangioma. Next question, a 29-year-old female presents to the dermatology OPD with this finding. Again, we do not have the actual image, so I cannot tell you what was the image that was given to you. But I think it was something similar. And if they had given you an image like this, and the options that you had given me, it's a little confusing because you see a lot of lesions here. So, but look at the predominant lesion. When you look at this picture, what is the first lesion that strikes you? It is these lesions. So what are these? These are nothing. These black lesions are comedones. They are black comedones or open comedones as we call them. And we already know that these comedones are characteristic feature of acne. Okay, so again I am giving you few important points because they may have been there in the question. Now, what were comedones? Comedones is basically, so what were comedones? So comedones are basically these the pilosebaceous duct which get blocked in acne lead to a special kind of lesions called as comedones. In dermatology we studied their primary, secondary and special lesions. Comedones are a type of special lesions which are seen in acne, and they appear as blackheads. They appear like this. They are dilated pilosebaceous follicles which are seen. Now in this image there is a slight confusion because I can also see some papules and pustules. But what is my predominant lesion here? That is the comedones. You see multiple comedones, so don't get confused, whatever be the options. Though I'm sure they must not have confused you with this, but if in the image even there were some papules and pustules, you would mark comedones as the answer because that is the most characteristic finding here. Okay, and or they would have given us you an a like 29-year-old female, an age where you can get acne. Okay. Uh, Coming to the next question. A 45-year-old truck driver with history of multiple sex partners presents to the dermatology OPD. Now, you know by now that whenever there is a truck driver in the history, we are dealing with an STD. And on top of it, it is giving you multiple sex partners. So we already know here from the first line of the question itself that the question would ask me about one of the STDs. Now, when we think of STDs, we think of ulcers, we see a discharge. But here what I have is an image of a hand which is showing some lesions on the hand. Again, a very, very characteristic finding which is seen in secondary syphilis. What is this? This is BO sign. You see these macular lesions on the palms of both hands in a patient with secondary syphilis. This is nothing but macular syphilid, or it can even be papular syphilid. And where do I see this? I see this in a patient of secondary syphilis. Now there are 2-3 pointers here. If these were the options, you don't even have to think. You don't even have to look at the image. Look at the question. I am sure they are asking about an STD. Look for an STD. What might confuse you? That they have given you palms, and in STD you usually expect a genital lesion, a genital ulcer, a discharge. But we have studied, we know that syphilis can present with a lot of manifestations in the skin, especially secondary syphilis. Secondary syphilis we know is a great imitator where you get maculopapular lesions all over the body. When they are present on palms, it's very, very characteristic because when you press these lesions, patient winces in pain, a sign which is used in the OPD to elicit whether the patient is of secondary syphilis or not. Now, just looking at the image, I cannot differentiate it from lichen planus, scabies, or psoriasis per se, as I would say. But look at the lesions. They're very, very micropapular. Lichen planus would be more violaceous. Scabies, if they had to give you, they would give you interweb space. Psoriasis would be more fissuring would be there, more scaling would be there. So classical picture, classical history, no confusion, secondary syphilis. Okay? Okay, so this was a little confusing. I don't think so we got the right options or anything. So a 50-year-old smoker presents to the hospital with painless oral lesion and white patch that develops in the oral cavity as shown in the image. Now, the options which I got was, I'm not sure whether they asked you about the diagnosis or whether they asked you about the treatment. So whatever it was, let's discuss it as a whole question. So a 50-year-old smoker. So when usually they give you a 50-year-old smoker with some oral lesion, which is painless. Two important things here, smoker and painless oral lesion. They would usually, and presence of white patch. A white patch in smoker, which is painless, would be leukoplakia. Would be leukoplakia, and leukoplakia is a precancerous dermatosis. We know that. Okay, so if these were the options, smoker, painless, white patch, it would be some form of leukoplakia. Leukoplakia is a precancerous dermatosis. How do we manage that? You have to stop smoking. If there was a patient was taking tobacco, you have to stop tobacco, areca nut or tobacco chewing, and you have to monitor the patient regularly and go for a biopsy. That is what is the the sequence of events if this was the question. So the diagnosis, if they had asked you, it would be leukoplakia. If they had asked you how would you manage, then cessation of tobacco and biopsy, right? Now let us look at the other options. Candidiasis is usually not painless. It is usually not painless. It can present with white patch, but usually there would be some kind of symptoms which will be associated with that. Candidiasis can be atrophic, it can be hyperplastic, it can present with similar white lesions, okay? But then again, the history of smoking and painless rules that out. Coming to lichen planus would usually present with violaceous lesions even in the oral cavity or oral ulcers. So when we see white patch, we don't think of lichen planus usually, okay? So, and again, lichen planus is very symptomatic. It is not painless. Then coming to oral cancer, yes, it can be. So it can be leukoplakia, which is usually precancerous. So that is why, based on this question, since I don't know the exact question, I cannot tell you what would be the answer. But I'm telling you that if this was the question and they have asked you about diagnosis and leukoplakia was an option, you'll mark that. If it was what should be avoided, cessation of tobacco. But if the question would have shifted to painful lesion, then we would have think of other options. Now I just would try to look into the what options you are giving me. So somebody has asked me that why not lichen planus. So lichen planus would not be painless, it is painful, and there are either erosions which are present in the buccal mucosa. The most common form of lichen planus is reticular type. So usually you would see a reticular pattern, or it can be erosive form, or it can be an ulcerative form, okay? Usually when they tell you that there is a white patch present, don't mark lichen planus. uh, Erythroplakia, somebody has mentioned, is the maximum risk. Yes, erythroplakia or erythroleukoplakia or leukoplakia are all forms of precancerous oral erosions, and if they were there in the options, you can mark that as the answer. And okay, so somebody there's someone who's telling me that there was lichen planus nahi tha, Wickham's try was there. So if they had given you Wickham's try, so Wickham's try is usually not seen in oral cavity. Wickham's try is seen on the skin. In the oral cavity, they give you a reticular pattern of lichen planus. Okay. uh, any Now I'll wait for, I think these were the questions. There's one more question. So a 50-year-old presents to the dermatology OPD with the white patchy lesions as shown in the image below. Now again, very confusing. It cannot be white patchy. If this was the image which was given to you, they would have given you a scaly erythematous lesions. And if this was the kind of image, then you would think of psoriasis. We all know psoriasis presents as erythematous patch with silvery white scales. So what they would have given you was with plaques with silvery white scales. If this was mentioned in the description, that you had silvery white scale. So whenever in dermatology they talk about silvery white scales, you do not have to think anything but psoriasis. Okay. Now, but let's look at the other option. Fungal infection, if would have been given here, they would have said either annular or ring-like lesion with central clearing. There can be scaling, but it would be in the periphery. So peripheral scaling or peripheral crusting may be there. So if that was there in the options, this would be the answer. Secondary syphilis does not present like this. Usually you would get, if they want to talk about secondary syphilis on palms, they will give you the characteristic image which I already discussed. Maculopapular drug eruptions, again, maculopapular drug eruptions can have varied morphology, but it would not present with this characteristic scaly, well-defined erythematous plaque. Okay, so that is something that we need to know. Now I'll just go in through your chat to understand whether you can give me some better options and I can discuss accordingly. Okay, so for the infantile hemangioma that we discussed, someone said the options were Melia and Mongolian spot. If they were the option, Mongolian spot would be blue. It has a typical bluish hue, so it would not be red. So that would not be the option. Comedones, they had given the acne vulgaris imaged and asked the first. So in the comedones question that we discussed, somebody had told me that they had given acne vulgaris image, and they have asked you what was the first lesion seen. Even if it was the first lesion that you see is a comedone, and that should be the answer. So comedone is the characteristic lesion of acne. It is usually the first thing that happens in acne, in the pathogenesis of acne. Okay. Okay, so okay, so I think there was one question on lichen planus. So whether there are lymphocyte deposits in the epidermal junction, this was also a question. Okay, so if they had asked you about histopath of lichen planus, so the various findings that they would have given was either hyperkeratosis, wedge-shaped hypergranulosis, and if they had mentioned about basement membrane zone, so there is a basement membrane zone degeneration with a band-like lymphocytic infiltrate. So if there was something like this, if there was a histopath question, then you would say a band-like infiltrate of lymphocytes, which is there at the dermoepidermal junction, is the correct option, and you could have marked that. Is there any risk of malignancy in oral LP? Yes, there is a risk of malignancy in oral LP, but I think was okay. So again, in the psoriasis question, I I'm getting some inputs that probably they had also given you nail pitting. Now, nail pitting is a very characteristic feature of psoriasis. You see deep, random, irregular pits on the nail plate. So, if there was an image which was showing these silvery white scales on an erythematous plaque with some nail pitting, again, psoriasis would become my option. Okay, so I think I think we have discussed most of the questions, and thank you so much for giving me inputs on what were the options and what might have been the question. And if there are any more questions, please ask me, or if you're helping me out with the options or any more questions, I'll be willing to take them here. So I'm not getting any more inputs here. So we'll end the session here. You're free to give your inputs later on also. And we'll upload the final questions soon on the PrepLadder app. Okay, so signing off. Good night. Sleep well.